Okay, good afternoon. Yeah, it's 12 now. And I'm Hasan Jalalod'Din. I'm professor of neurosurgery and a neuroendoscopy consultant at Ain Shams University, Cairo, Egypt. I'd like to thank Dr. Mahmoud Qureshi for the invitation. I'd like to thank Mazen for the kind invitation from Karl Sturz. And I'm just trying to talk about complex issue. It's a complex hydrocephalus again, so I hope that I can present it in a simple way to just to know the important points in such an issue. Okay, this is from where I come. It's Cairo, Egypt, of course, and I hope every one of you can come to visit us soon. And this is the university where I work. This is the university campus. It is Al Za'faran Palace, and this is the hostel. We have a lot of hospitals, but this is the largest one, and this is the private sector of the university, not the other sector. Now, we have a definition for complex hydrocephalus. The complex hydrocephalus could be uniloculated or multiloculated. Of course, the most common to think about complex hydrocephalus is the multiloculated hydrocephalus, where there are multiple cysts or locules isolated with multiple interventricular separations. The less common definition for complex hydrocephalus is the uniloculated, where the single cyst inside the ventricular system. It could be supratentorial, as in case of isolated lateral ventricle, or infratentorial, as in case of isolated fourth ventricle. Generally, the uniloculated is congenital in origin, while the multiloculated is post-infectious or post-inflammatory or post-hemorrhagic in case of neonates. I'm going to focus mainly on the multiloculated hydrocephalus rather than the uniloculated. And these are some images of the cases that we are going to show the videos later. And as you can see, the multiloculated hydrocephalus, you have a lot of locules. You can't find a connection between them, and this will lead to the problem. The problem is that there is no uniform surgical strategy to manage such cases, and the current options for multiloculated hydrocephalus to use the microsurgical fenestration of the separate compartments, either by craniotomy or by endoscopy, or shunt surgery, in which case we use multiple catheters placed in the separate compartments, or we can use a combination of these modalities. So we can use the endoscope or the microscope in order to connect more than one compartment to each other. Then we insert one or two shunts, and we have stereotactic procedure. But again, this is a problem, because in case of placement of shunts, we have to use multiple shunts. We can use cystoperitoneal shunts. We can use multi-perforated catheters, where we use custom-made long catheters, or we use the ventricular catheters, and we add the holes in different positions of the catheter, not only in the tip, in order to tackle multiple compartments within the multiloculated hydrocephalus. We have the stereotactic aspiration, just simple aspiration of the isolated cyst or the segregated CSF, or even the stereotactic shunt placement in different compartments, or stereotactic fenestration. The multiple shunts have the instance of infection. The multiple shunts have the instance of infection and the mechanical obstruction, and their removal has been problematic with associated risk of intraventricular hemorrhage. As for stereotactic approaches, they are generally safe, but thick-walled or mobile cysts may be difficult to fenestrate and are likely to recur, because in stereotactic, we don't make wide openings. We just do small openings. And as we will see, the opening, the diameter of the opening or the dimension of the opening is very crucial in order to maintain the communication between the cysts. Okay. This is a demonstration of multiple proximal catheters, and this is a demonstration of the removed shunts. And the goals of surgery are to control hydrocephalus and simplify the complex shunt by replacing all the multiple shunts with a single proximal catheter, single reservoir, and single peritoneal catheter, reduce the shunt revision rate, avoid implanting shunts if possible, and decreasing the operative mortality. operative morbidity, I'm sorry. The available surgical technique in a comparison, we have craniotomy and we have endoscopy. And for craniotomy, of course, there is better visualization of the compartments and membranes, the easy fenestration and excision of membranes, wide communication of the cystic compartment, and the hemostasis is more easily achieved compared to the microscope. The microscope has the advantage of being minimally invasive, avoidance of brain retraction as compared to open craniotomy, and less blood loss and faster operation time and shorter hospital stay. But the endoscope has the disadvantage of handling of significant intraoperative bleeding is not easy, as we have discussed previously in the previous minutes, but intraoperative bleeding can usually be easily managed by irrigation or coagulation, as we said. And on the contrary, the disadvantage of craniotomy is that there is profound CSF leak, and this will lead to increase the chance of subdural hygroma and or hematoma collection, and may lead to shunt malfunction later on. So the current practice is fenestration of the septum pellucidum, septum pellucidotomy, fenestration of the intraventricular separations, foraminoplasty, aqueductoplasty, and EDV. So endoscopic fenestration tend to be performed more often for a treatment of multiloculated hydrocephalus, and the endoscopic management should be considered before placement of a second shunt. In some cases, require the staged endoscopic procedure to adequately communicate multicompartmental hydrocephalus. The techniques of simplifying multiloculated or multicompartmental hydrocephalus, the burr hole placement is usually very crucial, very important. We have to select the burr hole position to make the cortical passage as short as possible, and to make to enter the largest cavity, and from which you can manage the other cavities. The trajectory will take the endoscope to the membrane that separates the two cavities that need to be joined, and use the non-functioning pre-existing ventricular catheter tract to the ventricle, so you can remove just this non-functioning proximal catheter and introduce your endoscope through this trajectory. If there are multiple loculations, the trajectory should aim to communicate as many as possible, because we don't need to do multiple burr holes and we don't need to enter from many sites. And the membrane should be open with sharp technique with the diameter at least 4 millimeters. And this is the superiority of the endoscopic maneuvers compared to the stereotactic maneuvers. And if a patient has never had a shunt placement, attempts should be made to break down all the membranes before communicating or committing to extracranial CSF diversion. Guidance, guided neuroendoscopy. We can use ultrasonic guidance or we can use neuronavigation guidance. This is an example of the ultrasonic guidance for to tackle these cysts and to communicate these cysts with each other. And this is the example of the neuronavigation guidance. So for ultrasonic guided neuroendoscopy, it gives live feedback. This is the most important regarding the ultrasonic guidance. It gives data about the ongoing intraoperative orientation. It's extremely useful both in localizing and assessing the direction of the endoscope during surgery, and it optimizes the depth of the cyst or determines the depth of the cyst, and the presence of solid structures beyond the cyst wall could be detected, and all of these are with a live feedback ongoing surgical procedure, as compared, as we will see, with the neuronavigation techniques, the other neuronavigation techniques. Any shift of the internal contents during or after fenestration could be detected again using ultrasonic guidance, and evaluation of successful fenestration. This is a very important issue, evaluation of the successful fenestration and the communication between various compartments by viewing the line jet bubbles flowing from one cyst to another as seen on ultrasound. But still, ultrasonic guidance in neuroendoscopy is operator dependent. So when the operator is not experienced enough, ultrasonic may be a little bit cumbersome and may be misleading. And the requirement of a window in the cranial vault is another issue. So that in the pediatric age group, let's say in neonate, you can use it through the transfontaneller opening, but in above the age of 2 years in pediatric age group, it would be difficult because it's a burr hole. It will not allow the probe of the ultrasonic guidance. we have small probes, but still we have to do a larger burr hole to detect the endoscope through our operation. And there is potential crowding of the operating suite because we add another device to the surgical field. For the neuronavigation guided neuroendoscopy, the framed techniques are not have no place in pediatric age group and neonates. So we use the frameless techniques. There is no need for cranial vault window, and this is compared to the ultrasonic guidance, and they are machine rather than operator dependent, again, compared to the ultrasonic guidance. But the two important drawbacks, it is not real time, no surgical progress feedback, and there's shift of intracranial structures. As long as we open the first cyst, all the other structures will be shifted. How to overcome this disadvantage of both techniques? We can combine both technologies at the same time, and so that we can have the ongoing live feedback of the procedure with the ultrasound guidance, and we can overcome by this way the brain shift. And to control the brain shift, we can use the continuous irrigation to maintain the anatomical landmarks. I'm going to illustrate some cases, but they are away from the presentation, so we have just to escape. Okay, all of these cases are the cases that I have presented the emails before. The aim of this viewing of the videos of the surgery is not making an edited video, is to just show you that it's a lengthy procedure. It takes a long time, and you have to be patient during this maneuver, and you have to tackle the whole cyst as much as you can. So I'm going through the videos as rapid as I can. So the previous video. Here we are introducing the scope through the sheath, and this is once we get into the ventricular system, it's a little bit hazy, so we have to navigate with the scope in order to see the anatomy. As you can see, we have two fenestrations here. We proceed with the procedure. After navigating the ventricular system, we are aiming to see the transparent wall separating the cysts from each other. And these are the signs of previous infection and previous hemorrhage, as you can see here. I'm not sure if it is projected properly, but it is on the screen much more bright. After navigating through the whole ventricular system as much as you can, this is a rigid little lotoscope. Again, these are the signs of infection. We have chosen this part in order to communicate the two cystic compartments. And as we can see, we are just fenestrating the cyst. It's safe here to use electrocautery. We are away from tubercinarium. We continue with electrocauterization, and then we perform the opening. We can just introduce the ventriculostomy forceps and open the forceps in order. Actually, this is a grasping forceps rather than a ventriculostomy forceps in order to open the ostium and to widen it. Then we will introduce the Fogarty catheter, as you can see here, in order to widen the ostium or the opening. Then we inspect the cystic compartment we have opened, and we continue opening and widening the fenestration as much as we can. The minimum is 4 millimeters in diameter in order to communicate both compartments with each other. This is inside the isolated compartment. We are doing another fenestration from within the compartment we have just already opened. Again, we are communicating more than one compartment with each other, and we are using the Fogarty catheter to enlarge the fenestration. Another case. This is post-infectious. And as you can see, the CSF is altered. And the membranes here are much more clear so that you can see the structures just behind. Again, we are navigating the ventricular system. We can see the choroid plexus here. Let's see. Yes. Then we start to communicate the compartments, the different compartments with the same technique. We use electrocauterization, bipolar cautery in order to make the fenestration and enlarge it with the Fogarty catheter as we have seen. This is inside the cyst. The CSF has been stagnant for a long time and the signs of infection are within. We are communicating the cyst from inside to another compartment. Okay, I have another case for uniriculated cyst, which actually has been an arachnoid cyst, quadrigeminal cistern cyst. And in this case, we have opened the, let's see the image at first. These are the images of the case. Just trying to enlarge. As you can see, this cyst is obstructing the foramen of Monroe and causing hydrocephalus, significant hydrocephalus. And then we managed to open the cyst endoscopically. We will see the video. This is introducing the sheath and the scope, and then here is the foramen of Monroe. We have the choroid plexus, the thalamus striate and anterior septal vein. And this is the cyst wall, as you can see here. And again, this is wall extending. We decided just to use this because it is much more transparent. So it would be much more easier to fenestrate it. Then we use electrocauterization again in order to make the ostium. And this is just from within the cyst itself. We are introducing the scope within the cyst. Here is from within the cyst. As you can see, the vasculature of the quadrigeminal cistern are apparent here and pulsations are transmitted. Then we continue enlarging the opening by sharp dissection. we cut as much more as we can from the cyst wall in order to avoid any recurrence of obstruction and any recurrence of closure of this cyst. There has been a point of bleeding here with the cutting, and we could control it just by bipolar electrocauterization. Here we go. As long as it is a minor bleeding, you don't need to irrigate and irrigate because the field is clear, so you can just use your electrocauterization to control the bleeding.
You're using bipolar.
Bipolar, yeah, bipolar. And this is, we are continuing dissecting the cyst wall as much as we can in order to remove as much part possible as we can and to have a very wide and large fenestration. As you can see here, this is the end result. We have moved a large piece of the cyst wall, and there is this free communication between the cyst and ventricular system, as will be shown in the follow-up images. Here we go. This is the choroid plexus again. This is the thalamus striate and the foramen of Monroe. Another fenestration in another point, and we continue just to communicate the cyst with the ventricular system. This is the follow-up imaging, and as you can see here, this is within 48 hours from the procedure. Okay. Another case of a quadrigeminal cistern. Cyst again. No, I would like to show another interesting case of post-infectious hydrocephalus and show the issue of having a double Lilliquist membrane. It would be demonstrated here in a nice way. This is the image of the child. And as you can see, this is one of the mega hydrocephalus. And this is the video. This is getting back to the foramen of Monroe. This is the foramen. As you can see, it's a long-standing hydrocephalus, and we have already septostomy already made. And as you can see, the choroid plexus, the thalamus striate, the aqueduct is already present. The foramen of Monroe is very wide. And here we have the floor of the tuberous cinerarium, the two mammillary bodies. It is translucent. And we have just introduced our ventriculostomy forceps. And as you can see, after opening the first layer, we have another layer. So we have just introduced our Fogarty catheter in order to widen the first layer. Then we introduce the scope to see the second layer. This is the second layer of Lilliquist membrane. And we are going to open it again with the Fogarty catheter. We are opening it. And still we have another membrane. So we have to widen this in order to reach the third membrane. This is some sort of a closed chamber technique again, as you can see. We are just using the sheath as a retractor in order to retract the stoma already opened, because we have a lot of flapping membranes. And again, we can see another membrane in the depth. So we proceed by widening this opening. And again, we proceed. This is the third membrane or the fourth membrane, maybe. Yeah. We are just opening it, but we are getting too close to the foramen magnum. And we have said that it's better to stop at this point. This is the end result with the spontaneous flow CSF. Okay. This is regarding complex hydrocephalus. I have two other cases to share with you in order to, I know that this is a little bit advanced level, but it's nice to know that we can manage other cases with endoscopy. As regards, first of all, as regards our recommendation regarding the multi-loculated hydrocephalus, the recommendations is that the keys to success of endoscopic treatments are early diagnosis and early treatment, and these are achieved in part because of the improved morphological and functional definition obtained using the recent MRI sequences, according to the company that produced the machine. And all efforts should be made to allow the widespread use of neuroendoscopy at an early stage of this disease, and this is what we are doing or trying to do in this course. And this is a case of oculitis. You can consider it as a complex hydrocephalus because this oculitis is causing a significant hydrocephalus. So, if you are going to manage such a case with shunt, you need to put multiple shunts. So you need to need at least two catheters in each side, because the communication between each side is obstructed by this colitis. And this is the video of this case we just entered, and this is the colloid material aspirated. This is the aspiration of the colloid material. This, of course, is an edited video for the sake of the time. This is the cyst wall, and this is the colloid material. We are aspirating the colloid material as much as we can, and again, we are taking by grasping forceps colloid material, and this is within the cyst itself. This is the cyst wall. We are electrocauterizing the cyst wall in order to avoid recurrence. And this is the aspirated contents, and this is the some parts of the cyst wall. These are the preoperative images, and these are the immediate postoperative image with near total removal of the cyst wall and no recurrence till now. Another case is of suprasellar third ventricular craniopharyngioma in a male patient, 18 years old, presenting with visual disturbance with immediate postoperative resolution of the visual symptoms. And as you can see, there is a solid part here in the sella, and there is a large suprasellar component just reaching the third ventricle and filling the ventricle. This case, I have also managed it endoscopic transventricularly, and this is the introduction of the scope through the right lateral ventricle. This is the fornix, and this is the foramen of Monroe, and this is the cyst, the craniopharyngioma cyst, and this is the choroid plexus. And then we are just electrocauterizing the cyst in order to open the cyst. And after opening the cyst, this is the classic craniopharyngioma fluid coming out. We are aspirating the cyst content. This is continuing aspiration, and as you can see, the cyst collapsed at all. So this is the cyst after collapse, and we are just introducing the scope within the cyst, and this is the residual craniopharyngioma fluid. This is from within the cyst. These are the preoperative images, and these are the immediate postoperative images. This is the amount that we have aspirated, around 30 cc, and this is the part of the cyst that we have removed. And thank you. Okay. Any question, any comments?
What system were you using to aspirate?
I'm using the Lotta. I have the big Lotta and the little Lotta. Yeah.
Interesting. Any patients involved in systems?
I have a few questions from someone that's watching on the internet.
Yeah, okay.
Yes, hi, this is Dr. John Bennett moderating from Miami. I have a few questions from Rakesh Av from New Delhi, India. One of the questions is chances of basilar injury. That's his first question. Second question is how to tackle bleeding into the ventricles. Let's start with those two, please.
Okay, so regarding the basilar injury, we have already made a discussion around 30 minutes ago, but again, to avoid vascular injury to the basilar artery, you have to use blunt techniques. You don't need to use sharp techniques, and you have to avoid using electrocauterization in function. I mean, you can use the probe as a blunt instrument to make your fenestration at first of the tuber scenarium. And after that, you widen this fenestration with the Fogarty catheter, but it is not recommended to use the electrocautery in function in order to cauterize the tuber scenarium, because this would lead to or may increase the chance of this basilar artery injury. Another issue is to avoid using the ventriculostomy forceps in a way that the blades of the forceps open in a way such that it touch the basilar artery, so that it has to be perpendicular to the artery rather than parallel to the artery, so that this is another way to avoid the basilar injury. And the most important, of course, preoperative is to study the MLs of the patient as much as you can in order to know the prepontine cistern diameter and the dimensions in front of the basilar artery, because sometimes you can see that the prepontine cistern is too small or too narrow in order not. It would be difficult to accommodate your instruments, and it will lead to increase the chance of basilar artery injury. So in these cases, you may think twice before just doing your ETV. So the preoperative studying of the MLs is very crucial and very important. Regarding the second question, as regarding the control of bleeding, and we have already discussed it in a panel discussion 30 minutes ago, the most important, again, is to know the anatomical landmarks and to follow up these anatomical landmarks as much as you can. If you strictly follow up the anatomical landmarks and you move your scope confidently and with slow movements, this is the guideline to avoid injury to any vessel. But still, with using these techniques, the chance of injuring a vessel and then having a hemorrhage could happen. And in this case, irrigation is the most important technique to control this bleeding. So you have to irrigate, and wait as much as you can. And you may irrigate for 30 minutes or maybe 45 minutes to have a clear field just before shifting to some new modalities which are not recommended to be used from the start, which are the dry field technique or the closed chamber technique. But they, as I said, these two modalities of controlling bleeding are not recommended to be used as routine methods. Any other question, John?
Yes. So Rakesh has one more question. What are the most common complications on the postoperative period, and how do we deal with those?
Okay, let's say that the most important, of course, is the failure of the technique or failure of ETV, because the problem is still there and you have to manage the problem. And whether you decide to do a redo ETV or to just go for a placement of a VB shunt would be a problem again, because you have already told the family and you have already counseled the family regarding the options, and you have already told them that the ETV is a better option rather than VB shunt. Of course, you have to tell them preoperative that the chance of failure is there, and we may use a VB shunt again. Another issue regarding the postoperative complication is the CSF leak from the site of puncture of the burr hole, and there are a lot of maneuvers and techniques in order to avoid this leakage. As we have said, that it's better to use multi-layer closure techniques. So if you can use a bone flap, if you can use a pericranial flap in a direction different than, or the opposite direction to the scan flap, if you can use a dural flap, as Dr. Mahmoud Qureshi said, and try to close it even if you have a small burr hole, try to use or to have a dural flap rather than the cruciate incision, and after that try to close the dura as much as you can. then you can pack the corticotomy site with gel foam or Surgicel whatsoever in order to avoid CSF leak. And if you have a burr hole wide enough, you can just plug this burr hole with bone wax. All of these techniques could help to manage the CSF leak. There are other less complications or minor complications such as infection, and sometimes in complex hydrocephalus, you will need to do multiple endoscopic surgeries in order to manage such a lesion. Dr. Mahmoud, do you think that there are other complications? Because our colleague from New Delhi is asking about the most important complications to tackle. Do you think other than CSF leakage, other than failure of ETV, is there other complications?
One of them, but an additional one, you've mentioned the most common ones, is obviously a large subdural hygroma.
Yes.
And that can be a bit tricky because people have tried putting burr holes and drain them like a chronic subdural, but they just continue.
Yeah.
I haven't used it many times, but had occasion to use a subdural, subgaleal sort of shunt.
Communication,
That has reduced it.
Mm-hmm.
I don't know how commonly you have used it, but that's something that is an additional complication because the hygroma persists.
Mm-hmm.
It seemed to be causing some kind of mass effect and prevents the brain, the cerebral cortex from expanding.
Yes.
So doing a subdural subgaleal shunt is sometimes that we use. Do you use that?
Yeah, I don't have an experience regarding this because all the hygromas I have with the shunts, not with the. Yeah. And yes.
And yes, what you said, we've done subdural peritoneal shunts, but monitored it in the dual space. It tends to obliterate in 3 months. So we're trying to make sure that if it's cleared within 3 months, you actually take it out. But if you do not, it gets all secured, and then you can't take it out. So I've done lots of use of failure of the subdural peritoneal.
Yeah, thank you. It's okay.
Thank you for the presentation. It was quite nice. Regarding the multilocated shunts, Neil said it helps to govern the decision of ETV. And you touched on it that you might do repeat ETVs. But in the case that you showed that had the stagnant with what looked like the colonies, when you saw that, did you already coming back? Do you do a washout? Do you look routine?
Yeah, in that particular case, maybe I have not showed in the video, but I managed to do ETV at the end of the procedure, and I do remember that it succeeded. I haven't succeeded in this particular patient. You know, thanks God, we don't have a lot of multilocated complicated cases because they are cumbersome cases, but the results are so far are good.
This is one of the situations where sometimes you cannot get to the tubercinarium, you cannot see the floor.
Yeah.
And rather than give up at that point, after having opened up the various systems, you cannot get to the tubercinarium or fluid into the basal system, is one indication where you might want to use lamina terminalis.
Yes.
You can widen that, get to the lamina terminalis, and open it. You've basically gone into the basal system without having gone through the floor. So this is one indication where one can use the lamina terminalis.
Yeah. I have used it once and it worked. But I think it's a nice technique.
The only problem is that
this is what
in the smaller ventricles.
It is it needs a little bit posterior per hole, and you are not planning this from the start. So
But if that is the main issue, it's still worth making a posterior burr hole and approaching.
You mean the same procedure?
Is in the same procedure.
Yeah. So you take the scope off and
putting it back, making another burr hole.
This is another important issue to discuss and to know your experience regarding biopsies from posterior third ventricular or pineal region lesions causing hydrocephalus, and if you are going just to make ETV and a biopsy at the same level. So do you use 2 per holes or a compromise per hole in order to tackle ETV and have the biopsy? What's your experience?
I think doing 2 per holes is more appropriate.
Yeah.
Because by doing a compromise, you're compromising the ETV,
yeah,
putting the phonics at risk,
yeah,
and not getting adequate
enough. Yeah,
enough.
Yeah.
So I think putting the burr hole for the ETV in the proper position, unless you can really widen it, that's a different matter.
Yes.
You can actually do a small cranial.
Yes.
In which case it will be fine, because then you can move the scope. But I would prefer putting the burr hole for the ETV in its recommended position, and then looking at the trajectory on the MRI scan and putting the burr hole. Hopefully, it will not be right on the forehead.
Yeah.
But if you can get it just behind the hairline.
The hairline, yeah, yes, it is.
That's more recommended rather than compromise burr hole.
Yeah. Any other comments? Any other questions?
The next references, were you able to connect it with the previous explanation?
In that case, no, because it's already within the ventricular system. So you can just connect it with the ventricular system. You don't need that. But I have made already an ETV in this case. But I have another interesting case if time